Welcome back, y'all, to another virtual shadowing session at Hearts for Health. Today, we're joined by Dr. Soberon. She's a board-certified physical medicine and rehabilitation physician or physiatrist, as well as the medical director at Encompass Health Rehabilitation Hospital of Greenville in South Carolina. She'll be talking a little more about herself and also the specialty. We have a few patient cases today, too, so I'm looking forward to that. I know that y'all are, too. I do have some reminders, though, for y'all before we get started with today's presentation. So if you're new to virtual shadowing or new to our program specifically, we do have a Q&A at the very end of each of these sessions. That Q&A is pulled from the chat. So if y'all have any questions for Dr. Soberon throughout the presentation, feel free to drop them in the chat and we'll go through them in the order that we receive them later on at the end of the hour. My second reminder and my last reminder is if you would like to stay tuned with more shadowing sessions, we have two great ways to do so. First, our Instagram page where we post flyers, and second, our email listserv where we also post flyers, but on a weekly basis instead of bi-weekly basis. On both of those platforms, we also do have other opportunities, especially at this time of year. We have a mentorship program for pre-PA, pre-med, pre-dental, and pre-pharmacy students, those four categories of students. If you fall into any of them, I'm sure you might be interested and definitely check it out. We have more information on our Instagram page where we just posted a flyer announcing our application in order to join as a mentee within that mentorship program. And we also have a couple of volunteering programs. Some of them are in person, some of them are virtual. If you'd like to look into the details, again, that's on our webpage, on our website, which is hearts4health.org. If you have any questions about our virtual shadowing program or our other programs, feel free to send us an email. We're happy to answer any questions that y'all might have. Our email is community@hearts4health.org. Again, we're happy to answer any questions, but I don't want to take too much time. So Dr. Soberon, feel free to take it away.
All right. Thank you very much, Michael. So again, I'm Dr. Soberon. I am the medical director at Encompass Health in Greenville, South Carolina. And I put together a short presentation to kind of go through a little bit about how I got here as far as my career, and also what a physiatrist does, and just a little bit kind of go through a few things. So as far as career path, I know for me, I actually was born and raised in Miami, Florida. My parents are Cuban, and they were both accountants. So I wasn't a first generation physician on my mom's side, technically on my dad's side, but I have two cousins who are actually physicians. There are 4 Dr. Soberons in the United States. If you look us up, one is not related to me. So, but I actually majored in economics. I wasn't sure what I was going to go into. And since my parents were in accounting, I said, well, maybe let's try the business school. I actually got a scholarship to go into the business school and started there. And it wasn't until about my sophomore year that I started thinking more of the pre-health route. I was the only non-pre-health student volunteering at the hospital. When we went through volunteer orientation, everybody was biology major, pharmacy, different nursing, and then there was me. I was actually a finance major. So everybody turned around and kind of stared. But I was there because I really enjoyed it. It was at a children's hospital. And later started doing some shadowing and working with physical therapists, thinking that maybe pre-health, more PT was my route. And really it comes down to who you're around. And in my case, those physical therapists actually steered me towards medicine and away from physical therapy. Right now, I mean, I'm a rehab physician, so I work with a lot of therapists who are very happy with their careers and would have probably been different. In my case, they steered me in the other direction. So, and so I actually switched to pre-health my sophomore year, taking a lot of science classes during the summer. Don't highly recommend that. Usually, if you take them spaced out, would be it's a bit better, but it can be done if you change your route later on. So I did volunteer, like I said, at a children's hospital. And I thought, well, I'm going to be a pediatrician. Sometimes we think we know what we're going to do. And in my case, when I went to medical school, started out looking the first 2 years, the general classes, did some clerkships and so forth. And actually started in my medical school, we had a continuity clinic, and a lot of medical schools do, where you stick with one specialty at least once a week or half day a week, even if you're in a different rotation. So even if you're in surgery, you still do half a day of internal medicine or a few hours of internal medicine or pediatrics. In my case, since I was really interested in pediatrics, that's what I did during my third year. And it was actually my first clerkship of medical school. And you think, oh, I'm going to love it. This is going to be great. And it was a mixed bag. So here I am. I am not a pediatrician, so that tells you everything. I found that I actually enjoyed a lot of other things too. It wasn't that I didn't like one thing, it was that I liked so many others. So I enjoyed orthopedics and sports medicine. I actually really liked my surgical rotation and opted to do a full month of orthopedics during medical school. And I just really liked a little bit of everything. So I started looking at what other fields could offer that. I also enjoyed working with different age groups. So physical medicine and rehab, I could actually work with children, and I have, all the way to 100 plus. So I enjoyed that range, just like family medicine and a few other specialties that you can really work with a lot of ages. So that's how I ended up with physical medicine and just really liking a little bit of everything. And I ended up training in Houston for physical medicine and rehab. So I did end up here in Greenville, South Carolina. Like I said, I'm from Florida. When you in medicine, you kind of shears, you move around a little bit. I met my husband in Houston, and he's from Louisiana. So this was somewhere in the middle for both of us in South Carolina. And that's how I ended up here for my first job. And I am board certified in brain injury medicine and physical medicine rehab. So my first job was actually a mix of inpatient medicine. I was in the hospital, also doing consults, and in a clinic. I did a little bit of everything. And I actually did work, they have a children's hospital too. So I did work with some pediatrics. And it was very rewarding. I enjoyed working with kind of the spectrum of the ages. But over time, things change and develop. You kind of start figuring out what you enjoy. And my focus and my passion was more the inpatient side. I love the flexibility. I love the different patient cases, the ages, and the flexibility of just brought for my life. So I have a friend and was actually a fellow ahead of me, a couple of years ahead of me, who is an associate medical director at an Encompass hospital in Texas. And she had told me for a few years, Angie, branch out, do something different, maybe private practice, which you hear a lot of doctors now employed by a hospital. And I was for many years, and I'm no longer technically. I'm an independent contractor, which is very different. That's a whole other discussion down the line. But so she pushed me to explore other options, what could be possible out there. And just turned out that a hospital was being built here, similar to the one that she works at in Texas. So just down the road. And I started looking at the job. And at the time, still in my 30s, and I'm kind of young to be the medical director. Started looking up what the requirements were. Do I have enough experience? That fear starts setting in. Can you do it? And I have full confidence in myself as a physician. And at the same time, you start thinking, can I supervise other physicians? Can I have an administrative role? Now, this was a totally different role for me. So there was some excitement, and at the same time, even before applying, a little bit of fear, which you start thinking, okay, let's deeper dive. So, but I went forward with it, and certainly the right decision for me. And that's my hospital there, the Encompass Health of Greenville. I actually started before we even took our first patient. We just opened 2 years ago, almost to the day. I started with Encompass July 18th of 2021. We didn't have our first patient until August 3rd. So literally 2 years to the day almost. So kind of an exciting time. It was a very busy time. So what is physiatry? Like I said, lots of different settings, but what is it that we actually do? I know you've had a speaker maybe about a year ago or so forth that was a resident of physiatry. And depending where you train, you get different takes as far as inpatient, outpatient. Some programs are very focused on one or the other, but it's a very broad spectrum type specialty. A lot of people say, hey, is that psychiatry? Very different than psychiatry. We do a lot of prevention, diagnosis, and treatment of folks that are disabled by disease or maybe an injury, a lot of trauma, motor vehicle collisions, motorcycle collisions, but also sports injuries, diving injuries. And these are some of the subspecialties. Like I said, I'm board certified in brain injury medicine too. Spinal cord injury is another medicine. Spinal cord injury medicine is another fellowship, as is pain. Pain for a while was really popular. People do go into pain from anesthesia, psychiatry, neurology, and others. But going into pain from anesthesia and physiatry are overall the most common. And then sports medicine also, as well as pediatric rehab medicine. We actually do the physiatry residency, which is 1 year of internal medicine or surgery, and then 3 years of PM&R. And then pediatric rehab medicine is another 2 years typically after that. So, and then neuromuscular medicine, like EMGs and testing as far as certain disorders. So this is just an example of a case. I've probably seen, I don't know, hundreds of folks like this in Houston, multiple level 1 traumas, but here as well. 23-year-old healthy male with essentially no medical history, sustained motor vehicle collision on one of the busier highways, and on impact felt loss of sensation below the nipple line. He did lose consciousness, likely due to pain and also blood pressure. Ended up at the level 1 trauma and later discharged to rehab. So one of the things to think about is sensation right at that line. What does that mean? But also later reported intense stabbing pain at both of the nipples, had not regained any movement or sensation in the lower extremities. He wasn't able to void and actually perform self-intermittent catheterizations. But he was admitted to a rehab hospital, actually went home. He had also upper extremity hand injury. So he wasn't able to fully maximize his rehab initially. So we brought him to our facility to work on the phase 2 now that his hand was working and able to weight bear through that arm, and he can truly be more successful. So one of the things that we kind of talked about when he came back, and I was very surprised because he had been in another rehab for about 4 weeks, was why he had that pain. So, and where he had it. So very classic, and anybody with a spinal cord injury, this is actually one of the tools that is free online, but the rehab physicians and others will use it to see where someone's level of injury is and the classification, because it does matter the sensation as well. So in his case, you see there, T4 corresponds where his area of pain was. And he had gone to several physicians, several people had told him, tried different things for the pain, and he couldn't quite understand why he was having that pain. And the same thing with his family, actually. All I had to do was whip out this picture, show it to them, and it all made sense. So it's very important to know the dermatomes, especially with what I do. But every nerve corresponds with that spinal cord level. So it really helped to kind of put a picture to explain it to this family. But with the fact that he had absent sensation, no mobility, he would be what we would qualify on this testing complete injury. So the Asia A classification, because he had no movement or sensation. So, and that's that T4 corresponding back to that Asia exam. So some of the things that we see in folks that have spinal cord injury that the rehab doctor works on is pain. There's certainly significant pain that you can't see, but it's very real. The sharp shooting, almost feeling like a toothache inside the body, and a lot of stabbing type pain. So it does correspond typically where the injury is, in his case, T4. Another part is the bladder and bowel function. When I would do consults in the trauma hospital, a lot of times I would even have nurses that would say, this patient's urinating and they're incontinent. And I'm like, are they? Their spinal cord injury. Let's check the bladder, and they had a leader in the bladder. Obviously not a good thing. So a lot of folks with spinal cord injury, then you would have to go ahead and use the intermittent catheterization. This young man was actually independent with his catheterizations, and if not, you do a Foley catheter. And then the bowels is something that, in medicine, you talk a lot about bowel and bladder because it has to do with predictability, because having accidents out and about, just as far as it's humiliating and embarrassing. So having a very predictable kind of scenario where they use the suppository and so forth to make like very predictable, and not have an accident, be able to have a very good social life and so forth. And for this young man, we have a staff member who's very functional, high functioning, actually our occupational therapist, has been very successful in his life with the same type of injury. So that mentorship and so forth was very inspiring to him, and he was very grateful. So a lot of things that that was just kind of the focus: education, blood pressure management, prevention, all very important in the care. So again, patients of all ages. We work very closely with other medical specialties. I mean, we take patients from cardiothoracic surgery, from neurology, orthopedics. So definitely knowing all your other subspecialties. And then at my hospital, we also have family medicine and internal medicine hospitalists, as well as neurology, pulmonology, and other cardiologists that also round. So just really have to know how to collaborate with others, other medical professionals, and also other clinicians and in the hospital. And I'll go into that a little later. And one of the things, kind of looking at where, if you are looking at a specialty in medicine or anything, is really looking at what setting. Because same thing for pharmacy, physical therapy, occupational therapy, any of those, nursing. There's such an array of settings in healthcare that kind of seeing what fits your personality. And the nice thing is you can change. So you're not if you're not sold on one setting, it's okay to change to another, as long as, your resume does look bad if you're moving around every 6 months or something like that. But if it's for different reasons and it's for really legitimate reasons, then I have friends that have worked in several settings over time. So, and those are just a few: acute care hospital, inpatient rehab, skilled nursing. So this was another gentleman I had, actually fairly female, actually, I had fairly recently. And she was actually in Florida vacationing with her husband. Unfortunately, he passed away in a motor vehicle collision that injured her. She had a left arm fracture also, but more significantly, was noted to be combative at the scene. Her Glasgow Coma scale was a 5 in the field, and she was protected, intubated to protect her airway, and later extubated. She was arousing to voice and tracks only to the examiner. So she did transfer to an LTAC. So you're kind of looking as far as for her with that level, what do you expect as far as looking at what her outcome in the future, and where she is as far as severity of her injury. So those are some of the things, looking at PEG tube, incontinence, pain, also poor cognition and memory, really no memory. She was in a state called post-traumatic amnesia. So not really making new memories and not much carryover.
You want us to move on to the next slide or wait for some?
I mean, if someone, as far as looking at, I mean, in this case, what are some of the things you would think give you an idea of her prognosis? I know that's a loaded question, without kind of, I know what I'm looking for in this paragraph to tell me a prognosis, but just maybe some thoughts as far as what can give us a better idea of how this lady is going to do.
Well, while we wait for some responses to roll in, maybe we can go through one question. And you mentioned, usually we'll go through kind of like what other specialties you considered, but you mentioned pediatrics.
Yes.
So as another question to add on to that, given how you've been very insightful about your career trajectory just in practice as an attending, it would also be great to hear your reflections on your trajectory in terms of being a pre-med, going from pre-med to medical school. What are some things that you tell your younger self if you could go back, or what would you change if you could go back?
Right. So I think for me, I was in a hurry. I felt like I had to finish college in a certain amount of time. I didn't enjoy the stages as much as I think I should have. I had to take the classes in the summer and just go. And it was based on scholarship. The scholarship money runs out after the 4 years, at least it didn't for me. So I was like, I want to get it done. Really enjoying that summer in between, and just taking a moment to just calm down and enjoy it all a little bit more. I mean, it's a lot of work. I'm not saying not to work. Definitely please work hard because it is competitive and so forth. I would say my mindset is different now, that just reflecting a little bit more, and the time that I did have off, truly enjoying it, because there's other times in your life where you're just going to get busier from here on out. So it's a matter of enjoying that time when you do have that summer off, or that time with a friend, or anything like that, that truly be in the moment and enjoy it. So
I'm sure, especially as people are going through applications, some well-needed advice. But from the chat, so far, we have motor vehicle accident.
So, and I can go through it, if you'd like me to, what
Yeah.
kind of dissecting it. So in this case, for a traumatic brain injury patient, some of the things I'm looking at are her age, 63, not 83, but not 23, like our other patient. And brain injury definitely matters. So not as good of a prognosis, given her age. I also am looking at her glaucoma scales, and I'll go through that later. This is low. Or I should mention, the GCS is based out of 15, so 5 is low. You want to be a 15. So certainly there. The intubation, not as much. And then other things like her orientation and so forth. What actually matters later on, this is like as an aside, is how long the person stays in this state. So the longer, obviously, being worse. She had been, by the time she came to us, about 3 weeks out of her injury, and still, I wouldn't even say oriented to herself. She would turn to the examiner, and if you were touching her, she would kind of swat you away. And so she knew where you were, and localizes, like I said, localizes the stimuli, but not necessarily really a lot of purposeful kind of movement or following commands, and that kind of thing. So really the big one that I was looking at here is just their glaucoma scale, which I'll go through briefly. And so this is something that you can see also, like EMTs and so forth, like on the field is who gives this number. So for eye opening, the person gets points. For verbal response, they get points too. And then also if they can follow commands. So squeeze my hand, move your arm, actually follow a command, versus you press their great toe and then they kick you away, or they can localize, or they withdraw from pain, versus actually following the command. So in her case, she was right there in that severe category. But I work with folks in all the different ranges. And this is definitely a lot of detail. If you look up the ranges, los amigos, if any of you have a interest in brain injury, you can look it up. This is actually really revised, a very shortened version. It's actually about 3 pages long and small little text. So if you want a good something to go through, as far as for any reason you're interested in brain injury, look that up. And that is a scale that we kind of look through the whole spectrum of how a person goes from no response, completely comatose, to doing things appropriately and awake and actually back integrated to the community and so forth. And that's just the range there. So some of the patients I work with are not the easiest patients to work with. And that's another thing. You work with people, and this is going to be in any field too, but some of my patients do get agitated. They can punch, kick, spit, cuss at you. And not always, but definitely have had my share. And it comes with that territory, and it's kind of working with them and knowing how to shift gears, and how you would speak to someone who has severe traumatic brain injury and is agitated is not how you would speak to, a colleague, and kind of learning that over time. And so in this case, this lady, one of the things that they called me about was she's scratching and hitting everybody. Nobody can touch her. All right. Well, we had to figure out why was that. She had a broken arm, like I mentioned. She had a feeding tube in her stomach, and she wasn't on anything, absolutely nothing for pain. This whole time she had a big old scab at the back of her head from rubbing it so hard back and forth. All that hurts. She had surgery on her arm. She had nothing, no Tylenol, absolutely nothing. And she had been in a stretcher for about 8 hours in an ambulance ride. So it doesn't take a genius to figure out maybe she's uncomfortable. Let's try something, at least Tylenol. Let's start there. After we got her pain controlled, and because she couldn't ask, then she actually would let you touch her, and she would start participating more. And then she started waking up, and it was actually very nice to see her start waking up after a few weeks, and was able to even recognize some of the staff that she had worked with and so forth. But it's just starting out with the little things, the common sense things. Sometimes have to look at those too. So interdisciplinary team, it's really with pre-health and so forth. A lot of the colleagues I went to school with, and then, it's everybody. I have a nurse practitioner that I work with closely, PTs, OTs, of course, nurses, nursing assistants, respiratory therapists, dietitians, speech therapists, case managers. The case managers are of different backgrounds. They're not all social workers. Some are nurses and other backgrounds too. So really working with a whole collaborative team in our setting. I don't think I put the pharmacist there, but pharmacy, we certainly work with them quite a bit too. And so in our hospital, we actually have to, Medicare, there's a guideline that we do have to meet once a week, and have our conferences and so forth. So we meet with that group that I listed there, and our patients do at least 15 hours of therapy per week, which for some people may not sound like that much. And for others, you'd be surprised. It's just so much. But it's about 3 hours a day. We do have therapy Saturday and Sundays too, just not as much usually. And for our folks at the rehab hospitals, they have to be a little sicker, more complex, just right from the hospital typically, and then they do need more therapy. So you hear about these like nursing home or nursing facilities. That's slower pace. So we're not that kind of hospital where I work. It's a hospital, not a facility. A skilled facility, I should say. So this is amputation is another thing that people think rehab, when people go to rehab, is for amputations. And we are all about getting better, and so forth. And then there's the other side of it too. So I had a gentleman who has a strong history, diabetes, tobacco, peripheral vascular disease. He came to us after a below-the-knee amputation because of all those things. And he had been confused a little bit for the last 2 months, and had some gangrene on pretty much every limb. It was different fingertips and so forth. Wasn't eating much, no feeding tube. He's on dialysis. And he required a lot of redirection just to stay awake. He could tell me his name, but that was about it. So what would be some goals? I mean, I'm a rehab doctor. I'm looking at this patient. Like, what's going to be really some goals for this guy? And can somebody like this do therapy? I mean, it's a lot. Has every limb involved. He's been through a lot. Have to look at the whole picture, and he's not eating.
I'll moderate the chat for any answers that come through, but let's go with one question while we wait. So for any students who at this point are starting to pick up a possible interest or would at least like to look more into PM&R or physiatry, I know that there are quite a few positions out there, technicians, et cetera, that are available to really anyone, or pre-meds at the very least, with some education under their belt. Could you go through a couple that any students could possibly get their feet wet with?
Yes, that's a great question. So we have the rehab techs. There are several that work in the hospital that are pre-health. I've had pre-OT students and PT and other pre-health students that are rehab techs. So they work with our therapy team, moving patients to and from their room, sitting with them during, like, if they need assistance with feeding, learning how to do transfers, and just even assist the therapist during the therapy session. So you do get kind of hands-on training there. Some work as scribes. So I have in other hospitals, I don't have a scribe myself, have a nurse practitioner, but in other hospitals, some pre-med or pre-health students have worked as scribes to kind of learn the language and be there with either a physician or nurse practitioner PA, and just be part of the team as well. So I do know that one of the medical directors in another facility in a different state had a pre-med student working with her, and then she ended up a couple of years later going to medical school herself. So, but there's been several, usually scribe, rehab tech. I've also seen where some folks start out as like a CNA. We have one right now that is going to be going to graduate school for PA school. And he wants to be an ortho PA. He's a college graduate, and he's on the floor as a nursing tech, but he has other aspirations and just wanted to really be in that hospital setting to learn more about the floor and those collaborations and be in the hospital.
And one more question to follow up on that. So right now in your practice, you're in Greenville in South Carolina. You trained in Houston, Texas.
Yes.
I know that those are some pretty populous areas. Could you compare what the patient populations look like in terms of demographics between Houston and Greenville?
Okay. So in Houston, certainly being one of the largest cities, very, very different. We did have a lot of traumas and so forth. I worked at different settings. So the patient population depended also on the hospital. Some hospitals had a little bit older population, more cardiac surgeries. They had cardiac transplants. So we saw more of those patients. They didn't do as much of the trauma. And then there was some of the other hospitals had the trauma patients, spinal cord injuries, the severe brain injuries. And those folks tend to be younger in age. And I would say demographics wise, I mean, for what I do, I see every socioeconomic, race, religion, female, gender, anything. So now in Greenville, same thing where I was at before, being a level 1 trauma center, and the rehab hospital is attached. Where I am now, it's a little bit older population in general. being that we see more of the Medicare population. I don't see the pediatrics anymore. I still see some of the younger trauma patients too. It's definitely as we go, I find it's a little bit older. If you do some of the like hip fractures or more of those kind of patients tend to be older, 60s and higher, usually a little higher, 70s and 80s. So it's different. I would say, like, I don't see as much of the violent crime here compared to what I saw in residency, the stabbings or gunshot wounds. I've seen my share though in Greenville as well, gunshot wounds, drug deals gone bad. I had a 14-year-old actually that they mistook for a much older patient. He's a big kid, 6'3", drug deal, got wrapped up with the wrong people, got shot in the head. And he was only 14. He didn't look it, so the other people didn't think he was 14. So that was here. So you definitely see a little bit of everybody. And then you literally can go from your drug dealer got shot in the drug deal to a 85-year-old grandma of 6 kids, and she'll bake you a cake or something. It's very, you see everybody, so every walk of life. And one thing you just have to learn and find ways to relate to everybody. I had one, he was kind of a jerk. I remember he fired every nurse on that one floor, and they had to bring a male nurse from another floor because he had fired everybody and people were crying. And he didn't mess with me because he said that I told him to stop it in ICU, and I was going to walk away and I wasn't going to take what he had to say. And he always told me, it's like, I respect you for that. You put me in my place. I'm like, yes, you needed that. So you just have to know to relate to people.
Absolutely. I think that's very, very relevant in medicine in general.
Mhm.
And just like you mentioned before at the very beginning, it just goes to show how wide of a spectrum physiatry applies to. So great to hear. In terms of answers from the chat, we haven't got any so far. We have one question about one of the earlier cases, but we can save that for the Q&A. I can throw out a couple goals that I was thinking of myself. So one of the concerns I definitely have is his level of consciousness. He needs redirection, constant redirection. So making sure that, first of all, we pinpoint why that is. And second of all, addressing it. That's definitely one of the concerns that popped out to me. Gangrene is definitely another one.
Mhm.
Stopping the progression of that. Those are the top two that I have.
Yeah, absolutely. So those were some of the things that popped out to us, and nobody had really spoken with the daughters about the extent of his issues. The memory, they had gone to different people and everybody said, oh, he's on dialysis, it's just from that, or maybe it's some. My thought was actually just you have vasculature everywhere, and this man has terrible vasculature. So working on his cognition was a big part of it. Unfortunately, he wasn't one of our success stories. Well, it depends how you view it. I take that back. We really identified early on that we needed to speak with the families and figure out what his goals for quality versus quantity of life, and how aggressive we were going to be with how he was doing, and what he would have wanted to. Because in the other hospital, they could have never pinpoint exactly what was going on cognition wise. Give him fluids, check labs, his MRIs and so forth didn't look that bad. So I'm thinking it was like a dementia process, because of how bad his vasculature was. And I say it was because we actually worked very closely with the family on identifying that he did not want a peg tube. He did not want, he had a living will, he did not want artificial means of nutrition, which there's only so much you can stimulate with pills and have somebody eat and give IV fluids until, if they don't want that, then we have other conversations. And that's a part of medicine where you have to see, not that we give up on folks. It wasn't about that for him, is finding dignity in his life and what he would have wanted, and just talk to the family. And there was a lot of hard conversations as far as what he wanted to be done. And one of our hospitalists was excellent with that, and getting on the same page, that understanding, yes, that's and agreed that we needed to really talk about what are the next steps. And you can do everything possible, but if the person isn't going to eat, then you have to look at everything else. So I could go to the next. I have some more positive ones too. The amputees are not all bad. So he was just very involved. So hospice palliative care is another part of rehab. I don't do it all the time because honestly, it's heavy having the conversations with families about their loved one, that they, their dad, their daughter, whoever it may be. Those are tough. I mean, you leave those meetings, at least I leave those meetings pretty, I need to go relax for a minute. It's tiring because it's sad. People cry. I mean, it's just a lot. So, and understandably so. So, this one was more of looking at what his quality of life was. When I put prosthetic, they had actually discussed prosthetic with this man, which I kind of look back and, I love my surgeons. Some of them are very good at identifying, okay, this is not a good candidate for a prosthesis. This is a good candidate. This gentleman had almost no use of the other leg. There was no way that a prosthetic was going to be functional for him. So I have another case that is a very different. So this one, there's actually a news story here in Greenville. I reviewed the case before he came, but he wasn't actually somebody I cared for. One of my other colleagues did. And when we first got the consult to review it, all we knew was he was 35 years old. He was confused. He had history of a splenectomy after a motorcycle accident. And he was bacteremic septic shock. So he ended up, unfortunately, with necrosis of all the limbs. They initially didn't want to amputate his legs, although they were mummified. And actually, I hadn't ever seen that documented like that, but it actually said no sensation, no movement, and mummified, which I thought was interesting. So from a rehab perspective, I'm like, that's not functional. I mean, you can't walk on legs that are mummified and don't have circulation, and that's not going to be a good thing. But they got a second opinion, and the gentleman did end up, unfortunately, with 4 limb amputation, 2 below the knee. Here, my big question is, why do you think he ended up with what he ended up with? Why would a 35-year-old become bacteremic and shock over strep?
We'll wait for some responses to roll in the chat. One more question I have for you is, you mentioned being an independent contractor. I don't think that's something that we've talked about ever on virtual shadowing, and we've had over 80 sessions now, so definitely a new topic for us. We've heard about private practice, we've heard about academic medicine, but could you talk a little more about what being an independent contractor entails, how it's different from those 2 other options?
Yes, so a lot of private, so I am technically private practice but I'm a solo person. I'm a independent contractor, 1099. So in the eyes of the IRS, I'm a 1099. I'm not a W-2. You hear about your W-2s. I'm a 1099. So I contract with Encompass. I have the privileges to work at their hospital. It is my hospital. As a medical director, I have a contract with them to provide medical director services. But I have my own LLC. I do my own billing. I have my own, in my case, I have a nurse practitioner who is also an independent contractor, and I contract her services. So essentially, for me, I'm not in a private practice like a clinic setting. So I am like my own show, if you will. But I have the ability that if I would want to work somewhere else as a 1099, I can do that work. My old job was employed with a hospital, so I had benefits and so forth. As a 1099, I get my own benefits through Blue Cross Blue Shield in my case. I have my own disability insurance and so forth. Some people find it scary. Again, fear sets in. Fear can be paralyzing. Don't let it paralyze you, please. I am in a setting where I'm an independent contractor. My husband is not a W-2. Some of the other doctors that are independent contractors have W-2 spouses. I am not. I could tell you we are a 1099 family. So we have, and for me, it worked because I do the compensation that I make and I bill directly the insurance company. I surrounded myself with good people that I have a billing company that I trust. I have, done my research on insurance companies that for healthcare, to cover myself and my family. And then we look at it, like 401ks or 403bs at different hospital systems. I don't have that as an independent contractor, but I have other investments and opportunities that I invest myself. So, or you can do your own 401k, like a solo 401k or an IRA. There's so many options, because I will say, people say, oh, I want to be employed because of all the benefits. Yes and no. I still have benefits. I mean, when you look at the money and so forth at the end of the day, I also have the autonomy. So I think I have more freedom now. I still have a lot of responsibilities. But I just get my own insurance and so forth. So it's different. It's a little, the private practice folks, it depends how they're private practice, because technically I'm private practice too. Excuse me. But if they work at a big private practice, then it's more like they're an employed physician. If they're a solo private practice like myself, then they're a 1099. And if they worked at a hospital like I do, they'd go in as an independent contractor. But you can be an independent contractor at an outpatient clinic. So for instance, some private practices would hire you for part-time work, just maybe 1 day a week or 2 days a week as a 1099. And what that would be is either they give you a certain cut per patient or per day. And then there's some like myself in the hospital, I just bill directly. The hospital does not get involved. As far as when I touch a patient, I bill the insurance for my service. But the hospital doesn't see that money for my service, nor do they pay me for that service.
We appreciate that in-depth breakdown. I personally haven't looked much into what independent contracting is, but that's a good framework to think of it as, like being solo as a private practice practitioner in a way. In terms of what we have from the chat, so far we just have a question about this case And one student wanted to clarify if this patient didn't go to the hospital in time. Is that what spiraled? Why the
Yeah.
spiraled?
Actually, so he presented pretty mildly. Um, and I can tell you, for him, it was actually the splenectomy. He did not have the right vaccines. It was something that at the primary care level was missed, unfortunately for him. He just had a simple, I mean, a 35-year-old athletic guy. He's actually very athletic, was working out and so forth. Just had a cough and a fever. He has two young kids, so he gets the school germs all the time. So I don't think it was a presentation, but that strep pneumo, there's a vaccine for people who've had a splenectomy. And unfortunately, unless you know to get it, they didn't give it to him. So that was one of the things that he put in his news. And the news was just, if you've had a splenectomy, go get the strep vaccine, because they only give it to older people. But if you've had a splenectomy, definitely, or you know somebody who has, that, make sure they have that, because that's the big one.
Okay. We don't have any other responses in the chat.
That's fine.
All right.
So some of what I do is usually work as a collaborative physician. Some days more than others, I'm the cheerleader for the patients, but so are the therapists and nurses. That's definitely in rehab and healthcare in general. Some days you have to put your smile, even though you don't have the energy. You just may need, that person may need it even more than you that day. And then diagnose what's going on and set a treatment plan. But those are some of the things I do on a day-to-day basis. And the medical directorship, some of the biggest things I had to learn the first 6 months, because the patient care stuff I had down. I mean, I've been doing this during residency and 8 years out of residency. I had all the rest down. Was the rest of the details of working with the department leaders, the ins and outs of what goes into a hospital, the flow, when something isn't going right, how to work with other departments to fix it and kind of get to the root of that issue. And then also just oversee the medical team and any questions and concerns, and be a liaison, really, and also the spokesperson, but try to get what I can for my team and go both ways and stand up for them too. Another part was recruiting physicians, and I've talked to residents and so forth about coming over to my hospital. Right now we're fully staffed, but definitely a big part of what I had to do at the beginning. And as we grow, we'll probably have to do it again. And I enjoy it, I should say. I enjoy that part. It's not medical at all. I really do enjoy that. So, and marketing, actually, going and because there's competition, because healthcare, we're all fighting for the patients. Not that I shouldn't say fighting. We're all trying to be the best choice, or but these are some of the settings. And my day to day is I round on the patients in the morning. I do some notes. And then if I get called during the day, I certainly go back and see them. I do some new admission orders and so forth, and have meetings. Typically, today was one of those heavier meeting days, so I still have a couple of notes to just review from my nurse practitioner. I did my set of notes, just kind of review a few things. And I'm technically on call, so, but.
have to juggle more than one thing at one time.
Yes, yes. An outpatient clinic, I did that for a while, actually, right before COVID hit, and went towards more outpatient clinic. And you have the scheduled time. Some people really like it. I found that I like the flexibility. I have two young kids. If I needed to step out and run out for whatever reason, it was easier to do in a hospital setting, versus if you have those patients scheduled from 8 to noon. If something pops up at 11, you're either canceling, you have some angry people, or you're there till noon. And that was just me. Some people love it. So, and it's just, you do know that those are your times. I just enjoy the inpatient setting personally. And then there's some hospital settings altogether. And this goes for other pre-health specialties, clinicians also. People work for insurance companies. You work for more governmental type settings like the VA, and just more administrative, occupational health, like a big major corporations. Like for instance, BMW has their North American plant in this area, and they have nurse practitioners and primary care services for all their employees at the plant. So those providers are just there for BMW employees. That's it. That's what they do. And also just acute care consultations and some contract work. We had a consultant that was a speech therapist that was a consultant for rehab hospitals. She doesn't see a patient. She just is a consultant about more of the documentation. So I think the biggest thing, and I learned this from, I think, more business, some with medicine. It really correlates. Everything comes down to respect, listening, professionalism, and being proactive versus a reactive. It's that one's the tough one. When you are faced with a challenge, it's easy to react and be upset or be anxious or insulted or what other emotion you want to state. Really, it's more about being proactive. If not letting the fear or anger really fixing and addressing what is at hand instead of reacting to it, because that usually doesn't always lead to the most positive outcomes. And really the communication. There's so many things in the hospital. We'll have meetings about flow, interdisciplinary, and the breakdown is 99.9% is communication. This didn't happen. It wasn't communicated properly, or it was there was a miscommunication. So that's just knowing how you communicate best. So we've actually talked, the CEO likes text messages and he likes email. Some others like face-to-face meetings. It really comes down, are you auditory? Are you a visual learner? All those things you hear about in your psychology classes and different things. It really continues. And in medical school, I actually had to take some tests. And even now, just a couple of months ago, took some tests about that too. So it doesn't, just knowing what to do with that information. And then Encompass Health, I took this from their website, the comfort, professionalism, respect. That's really, as any clinician in free health, they kind of can use that comfort, professionalism, respect. That's really comes down to with your peers, with your patients too, and leading with empathy and focus on the positive. So. And I would say work-life balance has been a tough one. You mentioned like with my pre-med self, I would say kind of getting that work-life balance is an ongoing challenge always will be your busy, just in general, as high achievers and just when you're goal oriented and so forth. Finding a hobby that you also enjoy, and then also just having some fun here and there. I know it's like we want to be serious, but we also have to enjoy life. And having a side gig can be that outlet. It doesn't have to be necessarily something that is financial, but if it leads to happiness, that's key. So there was a random trainer, a virtual trainer I went to at a gym class, and it said, if it doesn't help your health, happiness, or bank account, let it go. And that's true. Just let it go. If it doesn't, if it's making you unhealthy, causing anxiety, you have to reflect why that is. As far as getting into school, medical school, pharmacy school, what have you, of course, those things can lead to some unrest. But looking at it is that, are you doing that to cause, in the end, some happiness, something that a goal that you want to achieve? And the answer is yes, and you keep doing it. If the answer is no, and you're not going to be happy achieving that goal, then what will lead to that? So.
All right. Well, first of all, thank you so much, Dr. Soberon, for getting this all together. I love this presentation today. Like you said, we had a presentation, it's been over a year now, about physiatry before, but it's definitely been a while, and you had a completely new take on it. A lot of new concepts introduced here. So again, we do appreciate your time in getting this together and your time in staying with us here for the hour. Let's go through a couple questions. I know we're a little over the hour, but if you don't mind, maybe 2-3 questions before we wrap up. Does that work for you?
Yes, absolutely.
All right. So the first is, and this adds on to what we already talked about with independent contracting, private practice, and academic medicine. There's also travel work, an option that we've seen for a lot of nurses, nurse practitioners, and physicians, some physicians that have been on our program. Have you considered travel work? What are the pros and cons you see to it?
Yes, and I've considered it myself. I have friends from intern year that that's still what they do. I have a friend who's from intern year that has done that for several years and does locums at a rather 3 or 4 hour radius. I've considered it. I think I would, if I had to go back, maybe a few years back, I would have done it right after residency. And I've spoken with my cousin who's an anesthesiologist, and he says the same thing. Before I had kids, before I had settled somewhere, I, reflecting back, you have all these student loans. I wasn't making very much as a resident. Still carried those loans, and I was thinking, I just need a job. I need stability. That was in my head. Looking back, I'm like, why not? I would have traveled, done some locums, absolutely would have done that. I've thought about it now, more of on a local basis. If my local hospital is within a certain, and actually spoken with our CEO about that, within a 3 or 4 hour radius, needed coverage, I would do that. But again, I have a family now. My kids are 6 and 4, 6.5 and 4. So not the ages that I want to be away for long periods. But when they're older, sure, my husband's a realtor, we can travel, he should be here more for his business, but it would be something that I would look at. My cousin's husband is a hemonc that has done quite a bit of locums, and their kids are older already. They're away at college or actually out of college. So it's a little different, and he's done quite a bit of locums and has really enjoyed that. So I think I would do it, but not right this second.
Definitely. You have to consider what's going on in life. It just sometimes is all circumstantial. And on that same note, you moved from Houston to Greenville, right, for residency, and now as a practicing attending. What are some considerations that you have personally or that you've seen for colleagues when you have to make such a big move, especially with a family? What does it really take in order for you to be convinced that moving is the right decision long term?
Right. So it's a case by case. Certainly a conversation that I've had with many colleagues over the years. Some have moved several times already. And it comes down to, like, I've had, okay, some people move. I had one example, a colleague of my cousin's husband I mentioned, who does locums. He had a non-compete. He left a practice, very large practice of hematology oncology, had a non-compete that basically was 3 counties, and Florida, you can't go where he was east because you're in the ocean. So he just looked for the highest paying job he found and ended up in Alaska. So that was, for him, it was the money just to get past that 2-year non-compete. Other people, it's where you want to raise your family, and certainly where you want to settle and see yourself long term. And then other times it's the job, if it's the right setting, because you'd like to think that every opportunity is available at every time of the day, every time where you're going to look, and it may or may not. It has to kind of fit. People have to retire, or a hospital has to be built, or whatever setting may or may not be available at that time. And that's something that the opportunity does pop up later on, then you go for it. And for some people that's moving, and it's compromise. I had a friend who really enjoyed what she was doing in Indiana, and but Indiana wasn't for her husband, and for her, she loved her colleagues, loved the actual hospital. Just the city wasn't long term, so they moved. For us, it was a compromise, like I had mentioned. Location wise, my husband is not from from Florida. He's from Louisiana, so we kind of met in the middle, and he loves the mountains, so it's compromise. It's so many things, and for me at the time was the right. I did look. I'll give you an example. When I was looking after residency, I looked at. He was an engineer, an aerospace engineer, so we were looking at Pacific Northwest. We were looking at Texas. We were looking here because they have the automotive industry and some aeronautical as well. We looked all over, but it was the best fit, both the job and then where he liked it too. So it was a compromise.
Especially with family, I can understand that 100%. Well, that will wrap up today's session. I do have some last reminders for y'all while you stick around. And for y'all who are listening, our shadowers, we do have a quiz that's now posted in the chat. We also have that on our website and in our video description. That quiz will be due on Wednesday, August 6th at 11:59 p.m. Central Standard Time. Like I said, it's on our virtual shouting page in the chat box that y'all had your questions in, and also under our video description. If you have any problems with certification, you only need 6 or more questions correct out of the 10 in order to pass. But if you have any problems with receiving a certificate, definitely feel free to email us. I have our email in the video description. And for next time, we'll be joined by Dr. Tan. She's an endocrinologist practicing in the Dallas, Texas / Fort Worth area. She's been named one of Fort Worth's top docs in endocrinology since 2012. She's been pretty involved in the community and definitely passionate about the field of endocrinology. We'll see her next week on Thursday, August 3rd at 7 p.m. Central. Again, we will not have a session this Monday. That's just something to keep in mind for y'all if you were expecting one this Monday. So next Thursday, I should say, is the next time we'll have a shouting session. And like I said, follow us on Instagram. Go ahead and subscribe to our listserv if you'd like to hear more from us. I do want to give a shout out to Encompass Health, who got this all together. We had Dr. Soberon today, and we'll also have Dr. Prashone. I believe he'll be on August 10th. Another medical director at a separate Encompass Health Rehabilitation Hospital. But a shout out to them for getting this all together. And a shout out to you, Dr. Soberon, for getting this presentation together. Like I said, I personally learned a lot, and I believe I speak to the students on behalf of the students too. I'm sure they learned a lot too.
All right. Thank you. It's my pleasure, Michael.
All right. Well, you all take care, and we'll see you later this Thursday.